Thank you, Sue, and it's nice to be here with all of you, at least virtually. So what I plan to do is to chat for about 40, 45 minutes or so. I'm going to give you some context about Alzheimer's dementia. We're going to walk through the 10 warning signs of Alzheimer's that I think you have access to the PDF form. We also have it on the screen. And then I'll talk to you a little bit about how we do an evaluation of a dementia or a memory disorder. And then we'll leave plenty of time for questions. So first, I want to put in a plug for the Alzheimer's Association, which has lots of wonderful resources and an excellent website for patients, for family members, for providers. And so some of the information that I'm going to give you tonight, you can find more about through their website. So I like to kind of start with some facts and figures to give you some context. So in 2022, more than 6 million Americans are living with Alzheimer's, and additional Americans have other kinds of dementias. Over 11 million Americans provide unpaid care for people with Alzheimer's or other dementias. And these caregivers provided more than 16 billion with a B hours valued at nearly $272 billion last year. In 2022, Alzheimer's and others dementias will cost the nation $321 billion. And by 2050, these costs could rise to nearly $1 trillion with a T. So as you can imagine, this is a very important medical issue. It's a very important public health issue. And frankly, it's a very important economic issue for our country. So as I go through some of the discussion today, hopefully it will give you a little bit more kind of familiarity with the condition and when might be time to seek further evaluation. So what we have in front of us is something that is available to people on the Alzheimer's website. And we also have it, I think, available to you as a PDF. And these are 10 warning signs of Alzheimer's. And I'd like to go through them with you. And we'll talk about what is areas of concern and what are sort of normal age-related changes that would not be a big concern. What I would tell you to begin with is that the most significant risk factor for Alzheimer's is basically living to an older age. And as we've gotten so much better at treating heart disease and diabetes and cancer, and where people are stopping smoking and we're treating hypertension and all the sorts of diseases that we've had that have would take people earlier in their life, as people are living longer because we have better access to medical care, one of the side effects, I guess, of living longer is being subject to the conditions and illnesses that come with older age. And Alzheimer's is a hallmark of that. And so basically, the biggest risk factor for developing Alzheimer's is actually living to an older age. But since that's not something that we can do too much about, and we all want to live to an older age, that's why we think of what are the warning signs that might prompt further evaluation. So number one, and these are not in any particular order, but number one would be memory loss that disrupts daily life. And memory loss is very common and is common for everybody as they get older. What it turns out is that for men and women, the high point of memory functioning is probably in the early 20s. So all of us, after we come out of the early 20s, start to have some decline. That's completely normal. And as they say, what is a typical age-related change? Sometimes forgetting names or appointments, but remembering them later. And when I do this in person for the senior class, I often ask to the audience, who's ever had that problem? Sometimes forgetting names or appointments, but remembering later. And I raise my hand, and I'm sure many of you have that experience too. So that's completely a typical age-related change, not something to be terribly concerned about. But if you find yourself forgetting important dates or events, birthdays and anniversaries, asking the same question over and over again, or increasingly needing to rely on memory aids like notes or electronic devices, And it's more than just the occasional forgetting names or appointments. That might be something that would warrant further exploration. Number two would be challenges in planning or solving problems. Some people living with dementia may experience a change in their ability to develop and follow a plan or work with numbers. They could have trouble following a familiar recipe or keeping track of monthly bills or forgetting to pay their bills. A typical age-related change might be making occasional errors when managing finances or household bills. How many people, don't do the math properly on if they reconcile their bank book? I'm not even sure how many people reconcile their bank book anymore, or transpose numbers when they write a check, right? That's not at all uncommon. So that does not mean you have dementia. But if you start to notice things above and beyond those kind of occasional errors, that might be something that would warrant further evaluation. Number three would be difficulty completing a familiar task. People who have Alzheimer's disease often find it hard to complete routine tasks, like driving to a place that they've been 100 times before, or organizing a grocery list, or for remembering the rules of a favorite game that they've played hundreds of times. A typical age-related change might be occasionally needing help to use the microwave or to record a TV show. I don't know how many of you have problems with figuring out whether it's the DVR or the remote controls. I know I do, and that's why we have, 18-year-olds helping us to do those things. So those sorts of things are completely typical as people get older. But if you start to notice that, like, you're getting lost driving to your daughter's house where you've been many times, or figuring out how to organize the grocery list that you've done so many times, those would be the kinds of familiar tasks that we would be more concerned about. Number four would be confusion with time or place. People with Alzheimer's can often lose track of dates, seasons, and the passage of time. They may forget where they are or how they got there. This is different from if I say to somebody, what's the date today? And, maybe they don't look at the calendar every day. Or maybe they're on vacation, and you know how you're on vacation, one day sort of feels like the next, right? Or you're in the hospital or something else where it doesn't really matter whether you know if it's Tuesday or Wednesday. So occasional confusion about the day of the week, but then figuring out, that's not at all unusual. But being off by the year or by the season or not knowing where you are, that would be something that would cause more concern. Number five would be trouble understanding visual images or spatial relationships. For some people, visual problems can be a sign of Alzheimer's. They may have problems judging distance, and particularly that often gets expressed while people are driving. They drive too close, or they have fender benders, or they damage their vehicle, or determine color or contrast, which can cause issues with driving. That's different than, say, visual changes related to cataracts, which is also a very common condition as people get older. And of course, the good news is that cataracts is quite remediable if you see your eye doctor and they can take care of that. But if your vision shows no problems with the eyes, no problems with cataracts or glaucoma or anything else, but you're having these problems about, really it's much harder for you to drive or do other complex visual skills than you used to, that might be something to warrant further evaluation. Sue, can you go to the next slide or the next page? There you go. So how about number six? Number six would be new problems with words and speaking or writing. People living with Alzheimer's may have trouble following or joining a conversation. They may stop in the middle of a conversation and have no idea how to continue or repeat themselves. They may struggle with vocabulary and have trouble naming a familiar object or using the wrong name. Now, a typical age-related change would be sometimes having problems finding the right word or remembering the name of somebody. I can tell you this happens to me all the time, that I forget the name of somebody, particularly if I'm pressured to introduce them to somebody new, and then I just blank out on their name. I know it, but just in that moment, maybe I'm stressed or anxious or it's a new situation, I'll forget a name. Or sometimes people will grasp for the right word. When it happens occasionally, that's not at all unusual, but if it's happening persistently, a lot of word finding difficulties, a lot of name finding difficulties, particularly the names of loved ones or really people who you see every day, that would be something that would warrant further evaluation. Number 7 would be misplacing things and losing the ability to retrace your steps. So a person living with Alzheimer's may put things in unusual places. They may lose things and be unable to go back over their steps to find them again. He or she may accuse others of stealing, especially as the disease progresses. Now, a typical age-related change would be misplacing things from time to time and retracing steps to find them. How many of you have forgot where your glasses are and discover that they're, on top of your head, or they're on the desk, or can't find where your keys are, or can't find where your smartphone is, right? Those are very sort of common. We all have those sort of moments. But if it starts to become more and more significant, particularly, you put your cell phone in the refrigerator, or you put your wallet in the microwave, really things that are quite inappropriate, or you start to accuse others of stealing or taking the things from you and being malevolent about it. Those would be the things that would warrant further exploration. Number 8 would be decreased or poor judgment. Individuals may experience changes in judgment or decision-making. For example, they may use poor judgment when dealing with money, or pay less attention to grooming or to keeping themselves clean. Now, a typical age-related change might be making a bad decision once in a while, like forgetting to change the oil in the car. Or you've all heard the stories about these scams, people send these phishing emails or call you up and they say, they're the Nigerian prince, and if you give them $1,000, they'll give you $200,000 back. And, people take advantage of sometimes older people and even younger people who misplace their trust. But we start to become more and more concerned when people do things like empty out their bank account and give it to a stranger, or are not able to sort of dress themselves properly and go out inappropriately dressed in bad weather. Those would be the kinds of things that might warrant further evaluation. Number 9 would be withdrawal from work or social activities. A person living with Alzheimer's may experience changes in the ability to hold or follow a conversation. As a result, he or she may withdraw from hobbies, social activities, or other engagements, and they may have trouble keeping up with a favorite team or activity. So a typical age-related change is sometimes people feel uninterested in family or social obligations. So that happens to all of us at times, right? But really here we're talking about something much more persistent. You used to love to go out and garden, and now you have absolutely no interest. You're apathetic about going out and doing it. Or you used to love to cook, and now you won't do any of that anymore. Or you used to go out to church, and now you don't like to go and do that anymore at all. So those would be the kinds of things that would warrant further exploration. And then number 10 is changes in mood or personality. Individuals living with Alzheimer's may experience mood and personality changes. They may become easily upset at home or at work, with friends, or when out of their usual comfort zone. A typical age-related change might be developing very specific routines of how to do things and becoming irritable when a routine is disrupted. Many of us have that situation. We like things a certain way, we like our house a certain way, and we don't really like people to come in and disrupt it. That's not at all unusual, but when it's sort of more extreme, when people get much more irritable out of context or out of proportion to a very minor change, or easily get discombobulated by a change that wouldn't have been the case 10 years earlier. That would be the kinds of things that we would warrant further evaluation. So these 10 things are not the exclusive. There are other warning signs, but these 10 really capture the majority of the areas that we would be concerned about. And so if you see, they actually give you some space after each one. So what you could do is, if you wanted to, you could print this out. And if you were concerned about yourself or about a loved one, you could print it out and maybe write some comments about what you've noticed or what other people have noticed, and then bring this to your primary care doctor and use this as a way of starting the conversation with a primary care doctor, or even sometimes starting the conversation first with a loved one. So let's say now you go through that process and you're filling this out for a loved one or somebody's filling it out for somebody else. And then you go to your primary care. And the primary care doctor is really the best place to start. Because when you have an issue about memory, there are lots of different things that can cause memory difficulties. Alzheimer's and other dementia is one type of thing that could cause memory problems. But there are other kinds of things that can cause memory difficulties, many of which can be addressed with appropriate treatment. So when you come to your primary care doctor with this list in front of you and you go through it, and so your doctor may ask you some questions about, well, what have you noticed? How long has this been going on? Has this happened kind of suddenly and abruptly, or has it happened in a more sort of gradual declining way? And to get sort of more information about what you've noticed and what people around the impaired person may have noticed. Then the primary care doctor might do sort of a screening cognitive evaluation that can be done right in the office. Usually it takes 5 minutes or so. And there they will do things like what's called a mini mental status exam, or sometimes it's called a MoCA, Montreal Cognitive Assessment. But it takes about 5 or 6 minutes in the office. They may ask some questions to test memory, to test orientation, to test things like attention and calculation and drawing and writing sentences. They may ask you to draw a clock or to name animals or things like that. And that can give them some basic sense as to if there is some cognitive impairment. Then the primary care doctor might order some blood work, because there are some medical conditions that can cause memory problems, particularly in older adults. These could be things like thyroid problems, vitamin deficiencies, things like B12 and folate, anemias, certain infectious diseases. And so the lab work will screen for any of those kind of medical problems, because if it turns out that that's the problem, let's say low thyroid, that would lead one in a different direction in terms of intervention. The primary care doctor might also ask about things like what medications you're taking, because medications and side effects of medications can sometimes cause memory impairment. They'll probably ask about drinking alcohol or using other substances, because we know that alcohol or other substances that, when misused, can also cause memory difficulties. Then they might order some head imaging, like a head CAT scan or an MRI of the head, to see if there are any sort of structural problems that are causing memory difficulties, whether it's the effect of strokes or a tumor or some other neurologic condition that might present as memory. And of course, the doctor, in addition to the mini mental status exam, will also do a physical exam, listen to your heart, listen to your chest, maybe do some neurologic examination to get a basic sense as to what's going on. So sometimes, depending on the results of that evaluation, the primary care doctor might be able to have enough information from that evaluation to give a diagnosis. And the evaluation might be basically complete at that point. And the primary care provider may feel like, well, I'm pretty confident, given the information that I have, that what we're talking about is Alzheimer's disease or another kind of dementia. I'm going to talk about the other kinds of dementia in a little bit. But sometimes the primary care doctor says, well, I'm not so sure. This is not so clear cut. It's a little bit of a gray area. I would like some further evaluation. And they may refer for a specialty evaluation. And that evaluation might be, for example, a referral to the memory disorder program at Bay State Medical Center. Our memory disorder program has been going on for more than 25 years. And so it's very well established and well known in the area. And we're really the only comprehensive multidisciplinary memory disorder program in Western Massachusetts, and take referrals from internal to Bay State as well as outside of Bay State. So what would happen is, if the primary care doctor would refer to the memory disorder program, the patient and the family would first be in touch with a nurse coordinator who runs our program. For many, many years, it was a woman named Sue Megas, who some of you may have had some contact with. Did a wonderful, wonderful job for 25 years. She actually retired, a well-deserved retirement last week. And so now we have a woman named Simone Masson, also a very wonderful, wonderful geriatric nurse who is now coordinating the program in combination with the geriatrics division. So a nurse practitioner with experience in geriatrics will do the initial evaluation, and really they will gather the history, they will gather the prior tests, they will do, say, a mini mental status exam or a MoCA or some other sort of cognitive evaluation. And then depending on those results, the patient may be sent for one or more further evaluation. And the further evaluation, the sound is unstable. I don't know if I can help you with that. Maybe Jeffrey can help you with that. But if you can go, so further evaluation might include a neurological examination or a geriatric evaluation, and they would be looking for other conditions that might cause memory problems. So for example, obstructive sleep apnea is a very, very common condition. People may have heard about it. As people get older, particularly if people gain weight, they will snore a lot, and they will have problems at night getting enough oxygen to their brain at night and get really low quality of sleep, and often will feel fatigued and can have cognitive complaints because of their fatigue and the lack of sufficient oxygen at night. So somebody might get evaluated, say, for sleep apnea, or if there's a concern about a seizure disorder, or if there's concern about strokes or other things, that might warrant further neurological evaluation. Or a patient might be referred to see a psychiatrist like myself. And what I'm looking for is, are there psychiatric issues which might be manifesting as a memory problem? Or does somebody have a primary memory difficulty, but also have associated psychiatric symptoms? So it is very common that as people present with depression, particularly later in their life, that one of the symptoms of depression can be memory difficulties and cognitive difficulties. And sometimes we have to tease out which is the primary issue. Is the depression causing the memory difficulties? Or is there an underlying memory disorder that's causing, say, apathy or anxiety or other psychiatric symptoms? Because if it's primarily depression, depression is quite treatable, particularly in older patients. And if we can successfully treat depression, and if that's the primary cause of what's going on, then the memory symptoms hopefully will see some improvement. So we look to sort of tease out, are there psychiatric issues, and are they primary or secondary? And finally, somebody might be sent for neuropsychological testing. And what that is really a much more detailed version, like a 1.5 hour, 2 hour version of the 5 minutes that goes on in the primary care doctor's office. So it's really a much more detailed version of that mini mental status exam or Montreal cognitive assessment that's done in the doctor's office. And after everything is done, and any of the specialists see the patient, and if there are any other tests that have been performed, after everything is done, then we put all the information together. We meet together as a group, and we come up with our impression, what diagnosis we are making and what recommendations we will make. And then we invite the patient and the family in for a feedback session to tell them what we think and what we recommend, and then give recommendations to the primary care doctor. We are an evaluation program. We don't tend to do long-term ongoing treatment and management. And so that is basically, we guide primary care doctors in terms of managing if there are any recommended medication interventions or other interventions. So that's kind of what happens in a nutshell in the evaluation of dementia. Let me just say a word about the different kinds of dementias, and then I'll say a word about treatments, and then we'll open it up for a question. So there are a number of kinds of dementias. Dementia basically means a progressive cognitive decline, primarily memory, but also can include executive function and other cognitive areas. Alzheimer's is the most common kind of dementia. Alzheimer's probably represents somewhere around 60 to 65% of all diagnoses of dementias. And Alzheimer's is basically the deposition of what's called amyloid plaques in the brain, in the neurons of the brain. And basically what the plaques do is they grow over time, and they're like gunk, which damages the neurons, clogs up the connection between the neurons, the synapses, and basically ultimately causes brain cells to slowly die. And fortunately, our brain is pretty resilient. We have a lot of brain cells, a lot of capacity in our brains. But as you get older, if you have Alzheimer's and you have this amyloid plaque all over your brain, it basically begins to cause more and more cognitive dysfunction. The other kinds of dementias would include things like vascular dementia, what used to be called multi-infarct dementia. And basically what that is like a little heart attack to the brain. It's the brain not getting the adequate blood supply, in the same way that if you have a heart attack, the heart doesn't get the adequate blood supply. And in the brain, in the heart, muscle dies. In the brain, it's not a muscle, but brain cells die. And so people who have had strokes, or even people who've had sort of mini strokes, what are called TIAs, transient ischemic attacks, or sometimes people have never even had a stroke or a TIA, but they've had microvascular changes in their brain that over time have gradually caused damage to their brain. And that leads to what's called a vascular dementia. Other kinds of dementias that we see include dementias that are associated with Parkinson's disease. Parkinson's, is a movement disorder. Also, people develop it as they get older. And there is a dementia associated with Parkinson's disease. There is what's called Lewy body dementia, which some people think is a little bit of a cross between Alzheimer's and Parkinson's disease. It includes some of the Parkinsonian features like shuffling gait or stiff arms or other Parkinsonian signs, but also includes very vivid visual hallucinations. People see elephants in their backyard at noon. And that would be a hallmark of Lewy body dementia. There can be other dementias associated with, for example, repeated head injury. You've heard of Muhammad Ali and other boxers who were in the ring for years and years and years, or football players who had a lot of head injury, and they develop what's called the dementia pugilistica, or basically a chronic traumatic encephalopathy due to multiple head injuries. People who drink very heavily for many, many years can develop an encephalopathy associated with alcoholism, Wernicke's encephalopathy, which is the result of years and years of excessive drinking. And then there are a variety of other sort of infectious or other conditions that can cause dementias. And sometimes we see dementias that are really multifactorial. That maybe it's a combination of Alzheimer's and vascular dementia, so-called mixed dementia, or a combination of vascular and alcoholic dementia. So sometimes we see that. The only way typically at this point to get an absolute certain knowledge of what a dementia, what's causing a dementia, is sometimes to look at a piece of brain under the microscope. And the brain has to be dead in order to do that. So we don't typically do that, obviously, while people are alive. But short of that, there are other ways that we can be pretty confident about the diagnosis based on the history, based on the examination, based on head imaging. And there are always new and improved techniques to help make the diagnoses more specific and as early as possible. Because there was some thought that, and I'm going to talk about treatment in a second, there was some thought that if we could recognize dementias early on, even before they might be called a dementia, even when they might be called what's so-called mild cognitive impairment. Mild cognitive impairment means people are not severe enough for us to call it a dementia, but it seems more than just age-appropriate memory difficulties. And so that sort of gray zone in between is mild cognitive impairment. Of the mild cognitive impairment, about a third of those patients are going to go on to develop a dementia, often Alzheimer's disease. About a third of the patients may actually find that their memory gets better, particularly if it's associated with sleep apnea or depression or some other reversible condition. And the other third will basically kind of remain the same. Maybe they'll have a gradual decline over time, but they're never going to get to the severity that we would call a dementia. The challenge we have is that we can't really predict among those thirds who is going to be the third that goes to develop, say, Alzheimer's disease. So if we were able to intervene and evaluate people early and somehow identify the 1/3 of mild cognitive impairment patients who are going to develop Alzheimer's disease, the thought is that if we could then bring therapeutic interventions early on, maybe we could then prevent the plaques from accumulating, for example, and alter the trajectory of the condition and basically prevent or really dramatically intervene with the progression of Alzheimer's disease. And that is, I wouldn't even say that's $1 million question. That's probably $1 billion question because of the economic consequences that I mentioned earlier. So what do we have currently in the way of treatment? So sadly, we have nothing that stops Alzheimer's disease and nothing that reverses Alzheimer's disease. That's just not what we're at in the state of the art in 2022. In terms of Alzheimer's disease, we have two classes of medications that what they do is that they don't impact the progression of the disease. What they do basically is they allow your neurons to be as efficient as possible. So as the Alzheimer's plaques are killing off some neurons, these medicines basically allow the remaining functional neurons to be as efficient as possible. And so the goal is basically to slow down the progressive decline and maybe allow somebody, say, to be safe in their home for another year before needing, say, a memory unit or skilled nursing facility. So these interventions can be quite valuable in terms of quality of life, but it's important to realize that they don't bring memory back and they don't stop the progression of Alzheimer's. So these would include things like cholinesterase inhibitors. These would be medications like Aricept or donepezil is a very common one, or Exelon is another common one. And again, how these work is to keep a brain chemical called acetylcholine working in your brain. They do have side effects, particularly gastrointestinal side effects, some nausea and stomach upset. But if people can get over that, usually they're pretty well tolerated. And people pretty much, if they tolerate it and if it's recommended, they're usually going to take it probably for a while, even into, say, the moderate to severe stages of their Alzheimer's disease. Another medication is called memantine or galantamine. Memantine or Namenda. Namenda is the brand name. Memantine is the generic name. And that works in a different way on a brain chemical called glutamate, which also is sort of there to help kind of promote healthy brain function. So one could be on both a cholinesterase inhibitor as well as memantine, Namenda. And sometimes the combination of both are prescribed for people with Alzheimer's disease. They're really approved for Alzheimer's disease specifically. Sometimes people will use them for non-Alzheimer's disease patients, but the reality is they're really approved for and studied for those patients. And that's really who the best evidence is for. For people who have clearly a vascular dementia, the things that we recommend are controlling vascular risk factors, the same thing we would say if you had heart disease. So control your high blood pressure, control your cholesterol, you control your diabetes, don't smoke, control your diet, things like that. And again, those are not interventions that sort of bring back damaged brain. We don't have anything yet in 2022 that brings back damaged brain, but they're designed to basically slow or forestall further damage. So I gave you a lot of information in a short period of time, and I see already on the chat that there were some questions. So probably in the interest of time, because I'm sure there are a lot of things that I didn't cover, but I could see already from some of the questions that those are going to be great topics for me to expand on. So why don't we, Sue, if you will moderate, and you can shoot me some questions, and we'll go see how that goes.
I just want to say great information. Thank you for that presentation. Fantastic. Yes, we do have several questions. The first one is, Do people tend to recognize the changes in themselves?
A great, great question. So the answer is sometimes yes, sometimes no. Sometimes people do recognize the changes in themselves, and they will bring it to the attention of their doctor or their family. But many times the patient who has memory problems is really kind of embarrassed and scared, and they have no interest in calling attention to it. And so if they will, they will cover up, they will confabulate, they will deny, they will minimize, and sometimes family members, unfortunately, go along with minimizing that or go along with saying, oh, it's not a big deal, because they're also afraid. They're afraid of the consequences. What will this mean? So in my experience, it is typically a family member or a spouse who ultimately brings the patient in for evaluation. But occasionally it will be the patient who notices it. What I can tell you is, this, of course, is pre-COVID when we would do it in person. But when I would have a person who would come by themselves and drive themselves to the appointment to complain about a memory problem, 9 times out of 10, they did not have Alzheimer's disease. Because if they were able to sort of first have the insight to see that they had memory problems and to drive themselves to the appointment by themselves, I could tell walking in that they probably didn't have Alzheimer's disease. But some, there are variable cases. So the answer is sometimes people will bring it up themselves, but frequently it is family members who bring it to their attention. So.
Well, thank you. The next question is, do other kinds of dementia present differently than Alzheimer's?
Yes. So Alzheimer's typically has this sort of slow, gradual decline, whereas a vascular dementia might be much more rapid and sudden, like somebody has a stroke or somebody has a TIA or some other sort of neurovascular event, and they could be going along and then they have this event and then they'll have a very sudden decline, kind of a stepwise decline. So that would be the hallmark of vascular dementia, but not everybody has those kinds of big strokes. Sometimes it is these sort of microvascular changes that are going on that people, it happens in a gradual way and people don't notice, for example. Or if somebody has these very vivid visual hallucinations, while they may not have such severe memory impairment, that would be the typical of a Lewy body dementia. So the answer is different dementias do present differently. So.
Thank you. Next question, is Alzheimer's hereditary?
A great question. And the answer is also yes and no. So there is a group of patients who have what's called familial Alzheimer's. And they are, the hallmark is that they present with Alzheimer's at an early age, early meaning before 65. And so if somebody presents with Alzheimer's, and we're pretty convinced that the diagnosis of Alzheimer's before the age of 65, that would be suggestive of a hereditary form of Alzheimer's. But remember that I said the main risk factor for developing Alzheimer's is living longer. So if you happen to have, mothers and fathers who had long age and they lived well into their 80s and 90s, they quite likely had some degree of cognitive impairment as they got older, because essentially everybody has some degree of cognitive impairment as they get older. So when we will do the evaluation, we'll ask, well, is there anybody with a family history of Alzheimer's or dementia? So if somebody says, oh, yes, my mother had difficulties when she was 90, then I don't really worry about that as a hereditary form of Alzheimer's. But if they were to tell me, oh, yes, my uncle and his 2 brothers all were diagnosed with Alzheimer's when they were 55, that would be much more worrisome. And for those cases, which are really not so common, those sometimes get some genetic study and other further evaluation.
Thank you. Next question. What do PET scans reveal about Alzheimer's?
So a great question. So PET scans, so let's talk about scanning in general. So there are CAT scans that you're familiar with, and CAT scans are basically a fancy X-ray. okay? Then there are MRIs, magnetic resonance imaging, and those are basically not X-rays, but those use basically a big magnet that, because of the water molecules in your body, basically the magnet can detect the images of the underlying structure. And those are both examples of what's called structural imaging. They're looking at the structure of the brain, okay, the CAT scan or the MRI. PET scan is really looking at functional imaging. And so what a PET scan does is it's looking at the function, meaning like really the blood flow and the metabolism of different parts of the brain. And so if you have a PET scan, now what is available is that you can have a PET scan and we can inject something into you, you know, like you may have had contrast with an MRI, with a CAT scan. We can inject something into you, into your vein that binds to amyloid. So it lights up the amyloid in your brain on a PET scan. So the thought is that that will help to detect people. First of all, we'll be able to have a clearer sense, is this Alzheimer's disease or not? But also maybe we would be able to detect Alzheimer's plaque before we would actually clinically diagnose Alzheimer's, because we could see the plaque even before it reached the level that it was causing function impairment. And then the argument goes, if we had something that, say, removed the plaque, we could talk about that in a little bit. If we had something that removed the plaque, then maybe if we knew about the plaque burden early, we would be able to go in and intervene earlier on before it caused as much brain damage. So we do use PET scans, but typically with this tracer, which binds to the amyloid in a very specific kind of way.
Sorry, I was on mute. Thank you.
That's right. Actually, while we're at it, why don't I say a little bit about this magic, and maybe somebody has this question about the medication called Aduhelm.
Okay.
That's the brand name. It has another name that I can't pronounce. But that is a medicine that got approved last year that basically caused a lot of stir because it was a monoclonal antibody that was designed to target plaque and basically dissolve plaque, break down plaque. And all sorts of companies have been working on this for a decade. The thought was plaque causes dementia, so if we could stop the plaque or fight the plaque, then we could reverse Alzheimer's. So lots of effort, billions and billions of dollars went into this research. And finally, a drug was approved last year. But it turned out that even though it was good at kind of killing plaque, that didn't seem to make too much of a difference in terms of the disease process. So you could wipe out the plaque, but essentially the damage was done already, and it didn't really make any difference in terms of the Alzheimer's process. So what happened was that the FDA approved the medication, even though there was not a whole lot of support that it was actually that clinically useful. But they approved it because there's so little out there to actually treat Alzheimer's. However, and you may have heard this in the newspaper, because the evidence was so equivocal and because neurologists and other doctors were so kind of unexcited about using the Aduhelm, that Medicare decided that they weren't going to pay for it. And of course, when Medicare decided, all the other insurers decided. So basically, you can't get it unless you're in a clinical trial, which is basically doing longer term studies of it, because it is not like the easiest medicine in the world. It's not a pill that you pick up at CVS. It's an IV infusion. One of the side effects is brain swelling, so you have to have imaging and monitoring and things like that. And basically, there was a fair amount of risk and cost, and it wasn't clear at all that there was that much benefit. So instead of the sort of blockbuster that the drug company hoped it would be, it turned out to be a kind of a nothing. So people are still trying to work on this area, but it means that research has now turned away from the amyloid, cleaning up the plaques, trying to look at other things. And also to see what can we do to identify patients at risk early on, because maybe if we intervene early on before the amyloid accumulates and does all its damage, that's where we can make a difference, not after it's already been detected and has been going on for some time.
Interesting. Thank you for that. I guess there is one sort of related, that we still have a number of questions, but there's one kind of related to the plaque. And the question is, does plaque typically accumulate in a given area of the brain, or is it all over?
So it's a good question. Typically, it accumulates in the areas of the brain that are associated with memory. So we'll see it in the temporal lobes, we'll see it in the parietal lobes, some in the frontal lobes. Those are sort of the areas that we're concerned about. You don't see it as much, say, for example, in the cerebellum, which is part of the brain back here, which has a lot to do with balance and things like that. So there are certain parts of the brain that we look for it. Yeah.
Thank you. Let's see. Why is it that I cannot remember hardly as much from my past as my husband?
That's a good question. Well, you're lucky you have such a husband with such sharp memory, so that's good. There are lots of reasons why people don't remember things from their past. Sometimes it's a dementia, but sometimes it could be lots of other things. I think that if you have a concern about your memories, printing out those 10 warning signs and going through it, maybe with your husband or another family member, and maybe if you're concerned, bringing it to your primary care doctor would be a good place to start.
Thank you. Is Alzheimer's more common in certain populations?
It's a good question. The answer is there are some people who get it from family association, but that's a really small number. There are some people who have speculated that certain groups of individuals, like Ashkenazi Jews or other sorts of ethnic groups, may have a higher risk. But we probably don't know as much about the sort of ethnic or racial aspects of Alzheimer's as we should, and we will know more over time. I think part of the challenge is that certain ethnic groups are less likely to go for treatment and evaluation, and B, they may have shorter longevities, so they're dying of other conditions and they're not living long enough to develop Alzheimer's. But we have yet to sort of say that, there are some races that are more prominent. There have been some speculation that Asian races, that Chinese, Japanese, other Asian races are less likely to develop Alzheimer's. And people have speculated, does it have to do with their diet, or does it have to do with other sort of health indicators? And so there's some, ongoing research in those areas.
Thank you. This is an interesting question. Are supplements or Prevagen or Nariva any benefit or a waste of money?
A great question, a common question. So Prevagen, right? And you see the ads, and it's something to do with jellyfish, right? It comes from jellyfish or something like that. So you remember that. So you first of all recognize these are not medications. They're not approved by the FDA. They're not studied. They don't really go through peer review, kind of rigid evaluation the way that medications go through. And when they're studied in a rigorous way, there's really not great data that it does anything. That being said, there are some people who take it and who swear by it and say it makes a difference. And there's no evidence that it hurts you, that it's harmful. So the bottom line is, if you want to take Prevagen or some of these other over-the-counter things, caveat emptor, you can do that. I don't think it will hurt you. Whether it's a waste of money or not, that's up to the beholder. What I can tell you is in the memory disorder program, we don't recommend any of those things. The only things that we would recommend medication-wise are the FDA-approved medicines like the donepezil or the memantine. But if you want to take the Prevagen and you think it helps you, and as long as you're tolerating it, more power to you. Sometimes people ask, well, what else can I do to sort of keep my brain healthy or prevent Alzheimer's? Well, we have nothing that you can take that actually prevents Alzheimer's. unless you die at a young age, which nobody wants to do that. But what we say is do all the other things that keep your body healthy. Get good night's sleep, be moderate with your use of alcohol and other drugs, exercise regularly, keep your brain active, whether it's crossword puzzles or whatever you like to do, keep your brain active, because we know that even though the brain's not a muscle, but the more active you keep it, the healthier it will be. Moderate your diet, have a healthy diet. So all the things that help in terms of good health and reducing vascular risk factors are going to be good for your brain too.
Excellent, thank you. Susan has an interesting question. Do you think an early screening at a certain age, such as 70 years old, could be worthwhile?
Well, that's like $100 million question. So people have said, well, if we could more routinely screen, in the same way that we screen for colon cancer or breast cancer or these other things that we're really good at screening for, if we could build that into the primary care evaluation, like, everybody would have a cognitive screen at 70 and maybe have it repeated every couple of years. That would probably capture a lot of this mild cognitive impairment. But then again, remember, we don't know of the people who have mild cognitive impairment, we don't know who's going to be the third that's going to progress to Alzheimer's disease. Mm-hmm. That being said, groups like the Alzheimer's Association and other interest groups will say, we would do much better if we could identify people with MCI, because then if we had treatments that could intervene at an early stage, that is where the value will be to sort of prevent Alzheimer's. I think people are beginning to feel that if we wait until we make the diagnosis, the damage is done already. Maybe we'll be able to slow down further damage, but the damage is done already. So wouldn't it be better to do screening? Now, right now, people will say, well, why do I want to screen? You have no treatments for me. So what good is it to know? All I'll do is worry about it, right? So that becomes the sort of balance. But ultimately, I think that is what we're going to see. We're going to see much more regular screening, like we screen colon cancer and breast cancer and other conditions, prostate cancer. And the reason why we do those is because we have interventions that make a difference. So when we start to have interventions that make a difference with the progression of Alzheimer's, that's when you're going to see screening take off.
Great. We just have a couple more questions. I think we have just enough time. Is there, Lauren, like to know if there is a link between Alzheimer's and agitation, getting angry more easily?
So that's a good question. You remember that in one of the warning signs was sort of that irritability. And of course, lots of people get irritable. And there are lots of reasons why people can get irritable. They can get irritable because they're depressed. They can get irritable because they have sleep apnea and they're tired all the time. They can get irritable because they use too much alcohol. Lots of reasons why people can get irritable. Patients with Alzheimer's disease or other dementias will also get irritable or can also get irritable. Because they may not want attention focused on their memory difficulties, or they get suspicious and paranoid about people, moving their things or taking their things, or because the routine is disrupted, or because they're very frustrated that they can't easily do the things that they used to do, or because the family says it's not safe for you to drive the car anymore. They say, I've been driving for 60 years. What do you mean I can't drive the car? So irritability goes along not infrequently with dementia, but there are also other things besides dementia that can cause irritability. And so that needs further evaluation.
Excellent, thank you. Okay, and one last question. Do you have tips for discussing concerns with a loved one?
So that's also a great question. And so first of all, I would direct you to the Alzheimer's Association website. It has a whole series of things about caregivers and family members. And you could also contact your local senior center, Greater Springfield Senior Services, Highland Valley Elder Services, other local elder services also can have that information. In general, what you want to do is, so you imagine if you were the person with the memory problem, right? You're probably scared. You probably want to minimize it. You The last thing you want to hear is that you have a diagnosis of Alzheimer's disease, right? So you may feel very defensive if you were the patient with a memory program. So then as a family member, how might I approach that discussion? So the things that we often get most concerned about are safety issues, right? Somebody gets into car accidents, or somebody has fender benders, or God forbid, somebody injures somebody, or somebody does something unsafe in the car, in the house. They leave their stove on and it causes a fire, or they don't handle their financial affairs appropriately, or things like that. So often safety issues are something that a patient can kind of resonate with. And when you bring it to their attention, you really want to bring it out of a place of love and concern and respect. What you don't want to do is argue with the patient. You don't want to say, how could you not remember that? That just happened yesterday, right? You don't want to be belittling or argumentative in any sort of way. So when you bring up the conversation, knowing that patients are going to be defensive and resistant, you want to do it in a place of love and concern and really all around their safety and their health. And oftentimes it's not a one-time conversation. Oftentimes it's going to be a multiple conversation. And sometimes, bringing it to the primary care doctor's attention, you could say, well, let's at least bring it up with Dr. Smith and let's see what he or she thinks. And then the doctor can have a more detailed conversation with them. So, but it is often challenging. I just want to say a little bit about caregivers and family members, because as I alluded to in the beginning with the statistics, for every Alzheimer's patient, there are family members who are very much involved in the care of that patient. And caregivers can get burnt out because it can be very challenging, particularly if you're trying to keep your loved one at home, which everybody would like to stay at home as long as possible. And that is great. And we encourage that as long as it's safe and comfortable for everybody and it can be managed. But so caregivers can get burnt out because it can become, as you might imagine, a 24/7 responsibility. And if a caregiver is not healthy and gets burnt out, then they're of no use to the patient and they're of no use, obviously, for themselves. So then you have two people who have potential safety concerns. So we really emphasize for families the importance of avoiding burnout for caregivers. And that can be things like bringing in additional supports, aides, VNA, home health aides, getting respite so that if you wanted to take a break for a few days and somebody else came in and took care of your loved one, getting additional supports through the Greater Springfield Senior Services or home health aides, things like that. And when it's time, having the conversation about whether being at home continues to be safe. Of course, there will come a time when it will not become safe and when you might have to look for a higher level of care. And it's always good, if possible, to try to do that with some advanced planning, as opposed to having it sort of come up at the last minute because somebody falls and breaks a hip and then there's an acute medical sort of issue. And then the decision gets forced to go into a skilled nursing facility. So when possible, it's always good to sort of try to plan and anticipate. But that is, of course, easier said than done sometimes. So.
Thank you so much, Dr. And Fang, for your expertise and time on this important subject. Appreciate you so much. Thank you.
My pleasure. Have a good evening, everybody.